Good afternoon, everyone. Thank you for zooming in today to today's health talk with Stony Brook Hospital and with the Long Island East End Librarians group uh, sharing these events with libraries on the East End and well throughout Long Island. And I'd like to thank everybody for zooming in today with the East Hampton Library, Shelter Island Library, Hampton Bays Library, Rogers Memorial Library, Hampton Library, North Shore Library, Cutchogue Library, Mattatuck Library, uh, Montauk Library, and Riverhead Library. If I've left anyone out, I apologize. But we have a large group. And without further ado, I'd like to turn over today's talk to Karen Wolfat before we get to Dr. Roppelt. So without further ado, Karen, take it away.
Thank you very much, Steve, and thank you to East Hampton Library for hosting this month's Health and Wellness Talk, sponsored by Stony Brook Southampton Hospital. We've been doing this for about 2.5 years now, and it's been a lot of fun. And we have programs scheduled through November, and just watch your local library newsletter for the listing every month. And without further ado, I am going to introduce Dr. Heidi Roppelt. Dr. Roppelt, did you get your technical difficulties ironed out?
Yes, I think so. Just give me a moment to share my screen.
Okay.
So I'm hoping I can pull up the presentation.
Okay, so Dr. Heidi Roppelt attended medical school at MCP Hanneman University School of Medicine in Philadelphia. Her internship and residency were completed at Stony Brook University Medical Center, as was her fellowship in rheumatology. Dr. Roppelt is an associate professor of clinical medicine at Stony Brook University Medical School and is also the residency program director in internal medicine, helping to educate our resident physicians at Stony Brook Southampton Hospital. And she is also director of scholarly activity. And she sees patients at Meeting House Lane Medical Practice at our office in West Hampton Beach. She's board certified in internal medicine and rheumatology. And it's my pleasure to introduce her to you today.
So hello, everyone. I really hope you can see my first slide. Karen, can you see?
Yes.
Okay.
Yes.
So welcome. I'm happy to talk about one of my favorite topics, osteoporosis. So I really hope that this topic is educational for all of you and helpful. So what is osteoporosis? It's a disease that's characterized by low bone mass and deterioration of bone structure that causes bone fragility. Now, when we talk about osteoporosis, many people talk about their T-score, and we're going to talk about what that means. But the actual definition of osteoporosis is not based on the T-score. It's based on how fragile your bones are. So even if you have a T-score that doesn't meet criteria for quote unquote osteoporosis, but you've broken a bone from a fall, you should not fall from a standing height and break bones. So that means that there is a concern for fragility. So osteoporosis is really bone fragility. And the most important thing that matters is, do your bones break more than what your actual score is? Of course, there's a correlation between a T-score that is particularly low and the likelihood of fragility. So they go hand in hand. And we'll talk about that in a few more slides. So the progression of osteoporosis, this is just a picture depicting in the same family 3 generations, grandma, daughter, and younger daughter. And obviously, we can see significant deformity and kyphosis in the older individual that has had vertebral fractures. And so her spine has curved. This is what we try to prevent. We don't want to see this, right? So we want to prevent bone loss that leads to those types of fractures. Okay, so we're going to talk a little bit about some myths. Myth number one, osteoporosis is not serious enough for me to worry about. Absolutely not true. It is a progressive disease, irreversible. So while we do have some medications that can increase your bone density somewhat, in general, osteoporosis is irreversible. Movements or bumps can cause a debilitating fracture. It can lead to chronic pain and disability, and there is an increase in morbidity and mortality related to osteoporosis. So it does lead to, an increased risk of death. Myth number two, I'm a healthy person. I do the right things, so I'm not at risk. Of course, this isn't true. Any postmenopausal woman is at increased risk for osteoporosis, and men over the age of 50 are at increased risks. Now, there are certain medications that significantly increase your risk for this disease, but just in general, aging, being female, put you at risk. Myth number three, I'm too young to worry about osteoporosis now. In fact, the time to worry about osteoporosis is when you're a teenager. That's when you build most of your bone. That's when you intake most of your calcium and increase your bone density to whatever the peak bone density is that you're going to achieve over the course of your lifetime. So really, the time to worry about osteoporosis is for me to give this lecture to high school students.
I'm sorry, the slides just aren't advancing. It's still on the first slide.
Is it advancing now?
No, it's still on the first slide.
All right, guys, I don't know what to tell you. I'm screen sharing. You know what? Let me stop the share and then start it again and see if that solves our problem, I hope. Are they advancing now?
Perfect, perfectly.
Okay, hopefully it stays with us. Myth number four, it's too late for me to do anything about osteoporosis. It's never too late. There's always treatments that we can prescribe that do help to increase your bone density, even if you've already been diagnosed with osteoporosis. And please let me know if the slides don't continue to advance. So a little bit about bone. So bone functions as a mechanical scaffolding. Obviously, it gives our strength to our bodies. It holds up literally holds up our system. It's a metabolic reservoir for calcium, phosphorus, magnesium, and sodium. It also contains metabolically active tissue capable of adaptation to load and repair damage. So a little bit about the bone remodeling. So what is the problem in osteoporosis? There's an imbalance between bone formation and bone repair. While you're sitting in your chairs right now watching this presentation, you have micro cracks that are being repaired. And so you have cells that are actually removing bone. These are called osteoclasts. And then you have osteoblasts that are filling in that hole as we sit here. So what happens in osteoporosis is that the balance between the osteoclasts or the cells that fill in bone and the cells that take away bone are out of balance. And the greater they are out of balance, the more bone loss you experience. So if we look at osteoporotic bone versus healthy bone, this is a picture just depicting what it looks like. And as you can imagine, this is a vertebra, so one of your spine vertebra. The holes that are present in the bone here are obviously less strong than, say, healthy, normal vertebral bone. So it doesn't take a lot of imagination to think of, this breaking more easily. And if we want to look at it on an actual X-ray level, this is healthy bone. The trabeculae are strong, wide, well-formed, whereas the trabeculae on the right are thin and obviously appear fragile. So osteoporotic fractures most commonly occur in the spine, usually at the level of T10, occur in the wrist, and occur in the hip. And this is just an X-ray showing what a vertebral fracture might look like, or a wedge flip fracture. So if we look here or here, this is normal in terms of shape, whereas this vertebra is actually compressed or crushed, and it's called a wedge fracture. So what is the prevalence of osteoporosis? About 44 million Americans have or are at risk for osteoporosis, which means 55% of all people over the age of 50 may develop osteoporosis. That's a huge statistic. We don't think about osteoporosis as affecting half of our population over the age of 50. 34 million more are estimated to have low bone mass, so they don't necessarily meet the criteria for osteoporosis, but they do have weak bones or a low bone density. 40 to 50% of women are affected, and about 20% of men over the age of 50 will experience an osteoporotic-related fracture, and this is what we care about. So it's not just enough that your bone density is low. What really increases your risk for morbidity is breaking a bone. An estimated 1 in 2 women and 1 in 5 men over the age of 50 will experience an osteoporosis-related fracture. That's a huge statistics. That's 50% and 1 in 5 with regards to men. The women's risk of hip fracture, just to put it into context, because we worry about things like breast cancer, right? Uterine cancer, ovarian cancer, those topics are very prevalent in everyone's mind or in the literature. But just to put it into context, a woman's risk of hip fracture is equal to the combined risk of both breast, uterine, and ovarian cancer together. Okay, so this is really a condition that affects many of our women and men. About 24% of hip fracture patients aged 50 and older die in the first year following their fracture. So again, just to hammer home the message that we really need to screen for osteoporosis and treat osteoporosis. Okay, so great. So we understand osteoporosis is an important disease. It affects our, many patients, but that irrespective of that, we still are underdiagnosing it and undertreating it. So we need to do a better job as physicians and as patients to make sure that we get screened and that we treat it appropriately. Men are not diagnosed as often with osteoporosis or even screened. It isn't considered to be a disease that affects men, although as I just mentioned, it is prevalent in men. So it is something that I encourage my male patients to get screened for over the age of 50, especially if they have any risk factors. So what are some of the risks for developing osteoporosis? Any personal history of a fracture over the age of 50. So if you've broken a bone after age 50, that you should definitely be screened. If you have a current low bone mass, so if you're on a medication, which I'll talk about in a moment, that might increase your risk for osteoporosis, you should get a bone density test. And if you have a low bone density, that puts you at an increased risk for osteoporosis and fractures. Being female is an increased risk factor. Being thin or having a small body frame, it increases your risk. Advanced age, so the older you are, the greater the likelihood that you may have osteoporosis. A family history of osteoporosis, in particular, if you have a family history of either a parent or sibling that has had a hip fracture, that's a huge red flag. Estrogen deficiency, so if for some reason you have gone through early menopause or have a low estrogen level, that's an increased risk. If you have eating disorders like anorexia and you have not, especially in adolescence, have not achieved your peak bone mass because of an eating disorder, that puts you at increased risk. Low lifetime calcium intake, vitamin D deficiency, so if you're not taking in enough vitamin D, certain medications like medicines for heartburn, medicines for seizure disorder can increase your risk for osteoporosis. There are certain medical conditions that increase your risk, like rheumatoid arthritis or other inflammatory arthritides. In men, a low testosterone level, inactive lifestyle. So you want to make sure that you're doing, 30 minutes of weight-bearing exercise 3 times a week. And by weight-bearing, we're talking walking, jogging, light, weight training, for example, all qualify. Cigarette smoking. So smoking increases your risk for osteoporosis. Excessive use of alcohol, more than 2 drinks per day. And then certain ethnicities, like being Caucasian or Asian, increase your risk for osteoporosis. So bone mineral density is crucial. It is the gold standard for diagnosing osteoporosis. It predicts fracture as reliably as, for example, blood pressure might predict your risk for strokes or heart attacks. And so what is a bone density and what is a T-score? So if you go for a bone density, and this is just a picture showing what the test looks like, it's actually a very low level of radiation. In fact, if you travel from New York to California on a plane, the amount of radiation that you receive is higher than what you would receive with a bone density. So it really is a very low radiation test, safe. And it's a fairly open machine for most brands, so it's not claustrophobic in general. And the results that we get from a bone density are called a T-score. What is a T-score? It's basically just a standard deviation from normal healthy bone. So we look at what is your likelihood or your score compared to, say, a healthy 30-year-old person of the same ethnicity and same age. So if you're a female, we're comparing you to a young 30-year-old healthy female. If you're Caucasian, we're comparing you to Caucasians. And it's a standard deviation below what is normal peak bone mass. So when you get a score of minus 2.5, which is the cutoff for osteoporosis, anything better or a higher number, more positive number than 2.5, minus 2.5 is better. It's called osteopenia. And anything minus 2.5 or lower is in the range of osteoporosis. So it's basically just a standard deviation. How much lower are you below someone who has a normal, healthy peak bone mass? And that's all a T-score is, okay? So who should we be testing? We should consider bone mineral density testing in every postmenopausal woman or men that are 50 or older, especially if they have risk factors. So certainly if you've had a fragility fracture or any kind of previous fracture from a fall, anyone that's on a medication that puts you at increased risk. So if you're on a PPI, for example, which is a medicine for heartburn, or if you're on a medication for seizure disorder, you should be tested. Patients that have thyroid disease would be a good idea to test, and anybody that has chronic inflammatory arthritis would deserve to get a bone mineral density testing. So what about treatment? Previously, we treated anybody that had a bone mineral density that was minus 1.5 or lower. I already mentioned that the cutoff for osteoporosis is minus 2.5. So anybody with a T-score of minus 1.5 is in what we call the osteopenic range. It means you're at risk for osteoporosis, but you're not actually bad enough to qualify for that level of low bone density. So we used to treat anyone that had a T-score of minus 1.5 and risk factors, or a T-score of minus 2 with medication. Our current protocol is to actually calculate what is your risk based on your bone mineral density for developing a fracture in the next 10 years. And this is called your fracture risk assessment, or FRAX score. And it's an algorithm that was designed to look at risk factors and calculate what is the likelihood over the next 10 years, based on your bone density measured at the hip, of developing a fracture. And if it meets a certain criteria, meaning it's more than 3% for a hip fracture, or more than 20% likelihood over the next 10 years for any other type of fracture, then you should be treated, even though your bone density is not in the osteoporotic range. So again, that calculation score is only to be applied to people that have a condition called osteopenia. So they have a low bone density, but they are not in the osteoporotic range. Anyone that has a bone density of minus 2.5 or lower, or has osteoporosis, should be on treatment. This is just, the website that you can go into to do the calculation. It's not really relevant for all of you, but my residents, are required to make that calculation. And then again, just to talk again about the risk factors, which involve increased age or gender, previous fracture, what is your bone mineral density at the hip, do you smoke, do you drink alcohol, etc. So we clearly need to treat postmenopausal women or men over the age of 50 that have a T-score of minus 2.5 or less. So you have osteoporosis, you need to be on treatment. We should treat anyone who has a bone mineral density that's not in the osteoporotic range, but in the osteopenic range. So their bone density is actually minus 2.4 or higher, that has a greater than 3% likelihood in the next 10 years of breaking a bone anywhere, breaking a hip bone, or more than 20% likelihood of breaking a bone anywhere else in the body. You should be treated. I'm not going to go through that. That's not as relevant for this audience. So what are the medicines that we use to treat osteoporosis? There are two main types of medication that we use to treat osteoporosis. One category is in the category of medications that are designed to maintain your bone density. So these are called anti-resorptive medications. They're meant to basically keep your bone density stable. We don't want you to continue to lose bone, but they really don't build a lot of bone back. So they're not increasing your bone density by much. They're really designed to just prevent you from losing any more bone. Then in the second category of medications, these are called anabolic medicines. They are designed to actually increase your bone density as much as possible. And they're usually used for either 1 year or 2 years at most. And then we put you on a maintenance medication. And these are medicines like teriparatide, brand name would be Forteo, for example, romosozumab, or the brand name is Avinity, if you've heard of these names, just to mention them. Of course, dietary supplements, anyone over the age of 50 or postmenopausal, if you're a female, should be taking calcium and vitamin D supplementation. How much calcium? You should take about 1,000 milligrams a day and in a divided dose. So either 500 milligrams 2 times a day, and you should be taking at least 800 to 1,000 units of vitamin D a day. So, and more is actually better. So you almost can't get too much vitamin D, but definitely don't take more than 1,000 milligrams of calcium. It increases your risk for kidney stones. And if you have a history of kidney stones, then calcium should be taken only through your diet. No supplemental calcium should be given. So many of my patients come into the office. They have been diagnosed with osteoporosis, or I make the diagnosis of osteoporosis, and they tell me, nope, Dr. Roppelt, I'm not going to take medicine. I'm worried about this condition called bisphosphonate-associated osteonecrosis of the jaw, or ONJ, osteonecrosis of the jaw. So I want to talk about the condition because it is so extremely rare, and yet it's such a concern for so many of my patients. What is it? First of all, just to show you what the condition is, it's where, and it's in a very particular setting. It occurs in the setting of having either implants put in or teeth pulled out. So if you're not getting those procedures done, your risk for osteonecrosis of the jaw is no higher than someone that is not on medicines for osteoporosis, okay? It basically is where gum tissue erodes or wears away over the bone. It can be treated conservatively with antibiotics and heal over, which is what this series of pictures shows. So this is a person that has an area of erosion over their jawbone, treated with antibiotics and now completely healed. In very, very, very rare cases, in an already very, very rare condition, you actually have to have surgery done to replace the portion of the jaw that's involved. But it's so extremely rare. So to put it into context, what is your risk for that very rare complication compared to your risk for breaking a bone or for other, conditions? So let's look at what is your risk for, say, anaphylaxis or developing an acute allergic reaction to an antibiotic like penicillin versus dying from a car accident versus dying from murder versus ONJ, which is the condition I just talked about, versus a fragility fracture, which actually is so hip fracture or a broken bone anywhere else in the body, so much higher. It actually goes out of the screen and, in comparison to these other conditions, just to put them into context. So how long should we treat people with, say, a bisphosphonate? These are medicines like Boniva or Actonel or Fosamax, just to give you some brand names that you might be familiar with. We used to treat patients indefinitely with these medications. It was believed that they had very low risk for, complication. They bind very avidly to bone, and so we treated our patients, indefinitely. We now recognize that there is an increased risk for fractures of the thigh bone because they're so good that they actually can cause your thigh bones to be almost too strong and increase the fragility or the rigidity of the thigh bone and lead to unusual fractures of the thigh. So we now recommend that in general, bisphosphonate therapy with medicines like Boniva, Actonel, Fosamax should be at most 5 to 6 years, and then have a talk with your doctor about whether or not you should stop your medicine. That's for the medicines I just mentioned. There are other medications that should not be stopped, like, for example, denosumab, or Prolia is the brand name. That medication cannot be stopped without putting you on a bisphosphonate, or you will lose whatever bone you've gained. So it really is dependent on the type of medication that you're taking, but it's a conversation after about 5 or 6 years to have with your doctor to say, hey, should I continue it or not? How is my bone density doing? Is it staying stable? Is it going down? Is it going up? And what is the risk for me if I stop my medicine versus continuing it? And those unusual fractures of the thigh bone, this is just an x-ray to show you what that looks like. It's not a hip fracture. So it's not in the typical place where we see an osteoporosis fracture. It's actually in the middle of the thigh. So a little bit about some of the medicines that we use to treat osteoporosis. So denosumab, the brand name is called Prolia. This is indicated for postmenopausal osteoporosis that for patients that have a high risk of fracture or that have failed bisphosphonate therapy. So you've failed things like Fosamax, Actonel, Boniva. It can be given to patients that have kidney disease. The bisphosphonates in general do affect the kidneys somewhat. So we use them a little more carefully in patients with kidney disease, whereas denosumab or Prolia doesn't have that problem or side effect. What are the concerns that we have about other medicines that we give our patients that put you at an increased risk for osteoporosis? So what is the real risk for, say, the medicine for heartburn called in the category of proton pump inhibitors? So these are medicines like omeprazole, Protonix would be one of the brand names of those medications. In general, I recommend to my patients there is a possible increased risk for developing osteoporosis. However, your risk of developing a stomach ulcer is significantly higher than your risk of developing osteoporosis from taking the medicine. So we have to weigh the risks and benefits with regards to whether you need to be treated for your stomach problem or your GI disease, or whether or not it puts you at an increased risk for a low bone density. So what about exercise? What can we do besides medication, vitamins like vitamin D, calcium, to help increase our bone density and at least maintain our bone density? Tai Chi in particular is very helpful because it not only is a weight-bearing type of exercise, it also it increases your balance and reduces falls. So I certainly recommend to my patients, if they have the ability to practice Tai Chi, or if they have a place that they can do that, it can be very helpful. In general, we recommend, as I mentioned before, weight-bearing exercise for about 30 minutes, at least 3 times a week. So again, in summary, osteoporosis is extremely common. It's associated with a substantial health and economic impact. Patients that suffer from osteoporosis do have an increased risk for morbidity and mortality. It is often silent, meaning you don't know that you have osteoporosis unless you break a bone. So the need for screening, the need to make sure that you get checked for osteoporosis by getting a bone density done based on your risk factors. So again, we talked about that. Anybody that's postmenopausal with risk factors like being on a medication that might increase your risk for osteoporosis should be screened, and any male over the age of 50 with risk factors should be screened. It's under-recognized and often undertreated. The improvement in bone health and reduction in osteoporosis-associated fractures are possible with the medications that we use to treat it. So what can we do? Conservatively, a balanced diet rich in calcium and vitamin D, or taking calcium and vitamin D supplements, is crucial. Weight-bearing exercise, which we talked about, healthy lifestyle, not smoking, no excessive alcohol use, and then of course medications that can help to increase your bone density or at least maintain your bone density are extremely important. So with that, I'm going to stop my screen sharing and I'll take any questions you might have. Anyone have any questions? You're welcome to unmute yourself and ask anything you might want. All right. We're all experts on osteoporosis, I hope. Can you not hear me? Karen, you're muted. I'm sorry. So it seems like people are having trouble unmuting, and I'm not sure. I don't know that I have control over that. Let me see.
We have a few
In the
questions.
chat?
Yeah, in the chat. So let's see. We have, are there any alternative natural treatments for osteoporosis?
So aside from calcium and vitamin D supplementation, there are no, actually that's not true. Strontium is approved in Europe to treat osteoporosis, and that is technically a vitamin supplement. it's not approved in the United States specifically for treatment of osteoporosis, but it actually has been shown in the literature and through studies to be helpful. So that may be an option, but in general, aside from calcium and vitamin D, there are no other, treatments except for exercise and so forth that might increase your bone density.
Do weight loss injections affect bone mass?
No. So medicines like Wegovy, or some of the other medications that are approved for weight loss are not shown to decrease bone mass.
And strontium
Strontium.
citrate used to treat osteoporosis?
Yes, again, it's approved in Europe. It's used in Europe to treat osteoporosis. It's a vitamin supplement. There's no significant downside to taking it, but we don't use it necessarily in the United States to treat osteoporosis as an actual treatment. I have no problem if my patients want to take it, but I don't use it instead of, say, some of the prescribed medications that I feel are more effective.
We have one. I've heard that calcium supplementation is related to cardiac problems.
So it's not related directly to cardiac problems. The issue comes in that cholesterol plaques and plaques that can affect your heart or affect your blood vessels do often contain calcium. So does calcium cause those plaques? Not really. It's really due to a cholesterol problem or a predisposition to having cardiovascular disease. So I can't blame the calcium for that. But yes, calcium is contained in those plaques. And I have many patients that are concerned about whether or not their risk for cardiovascular disease might go up if they take calcium. But the literature that has looked at this cannot prove one way or another whether that's the case. It's unclear.
How much vitamin D3 is too much?
You almost can't take too much. So for my patients, I recommend, 1,000 to 2,000 daily. I have patients that are on 5,000 units a day, and that's okay. Beyond 5,000, I would just make sure that you get your vitamin D checked, and just to make sure that it's not, that it's normal, because you don't need to take more than that if you have a normal vitamin D. And what is the vitamin D level in your blood that we expect that is expected to be considered normal? It's 30 milligrams. So if you get your blood test and it's above 30, then whatever you're taking with regards to vitamin D is more than adequate.
Do the antibiotics have the same risk of neurosis of the jaw as bisphosphonates?
No, antibiotics have nothing to do with osteonecrosis of the jaw. There are, but maybe so. Maybe the question. So there are a number of. I'm going to interpret the question differently. All of the osteoporosis medications do increase your risk for osteonecrosis of the jaw. All of them, not just the bisphosphonates. So medicines like Prolia, Forteo, they do have a potential increased risk for that complication. It's just, like I said, extremely, extremely rare. Antibiotics by themselves or other medicines don't increase your risk. And keep in mind, the risk is increased in a very specific setting. It's increased if you're having implants put in or teeth pulled out. That doesn't include root canals or cavities filled or general, tooth maintenance. It really is in a very specific setting.
Let's see, my lumbar spine T-score went down to 3.4 after Prolia. What are alternatives?
So I hate answering specific medical advice questions only because I don't know the case or the patient. But in general, if your bone density is going down on treatment, the number one concern I would have would be to make sure you don't have another condition that might be causing your bone density to go lower. These would be things like thyroid disease, parathyroid disease, or other, are you on cancer therapy or medications that might decrease your bone density? So number one would be to do screening to make sure that there's not a secondary cause for why your bone density is going down on treatment. That said, let's say, okay, so you had your screening done and no, there's no secondary cause. You still had a decrease in your bone density on denosumab or Prolia. I would recommend considering a medicine like romosozumab, the brand name is Evinity, or teriparatide, brand name Forteo. Those are more robust medications to increase bone density, cause new bone growth, but it's very unusual to have bone loss on denosumab. That's not common.
Can you continue on biphosphonate more than 5 years if you take a drug holiday in between?
Yes, you can. And it's a conversation to be had with your doctor. The recommendation is not to stop bisphosphonate therapy. The recommendation is to talk about it. So to consider discontinuing that medication. It's not that you have to. So yes, you can be on bisphosphonates, for much longer. And many of my patients have been. It's a matter of weighing what are the risks, what are the benefits, where's their bone density, has it increased, has it decreased, has it remained stable? Can we try a drug holiday and then follow the bone density, in the future and see where we're at, etc. So it really is just a reminder to have a conversation about stopping medicine. It's not an automatic requirement to stop it.
Let's see. Has Algae-Cal been studied as compared to prescribed meds?
It is a supplement. No. or maybe, but I don't know personally. I have no information regarding studies that have compared it to prescription medication. So I can't tell you whether it's less or more effective. There are no proven studies that have come out that show that it is equally effective or more effective than prescription medication. I'll leave it at that. That doesn't mean that it's not a good supplement or that you can't take it. It's just there's nothing that's been studied that shows that it's better.
Should women on thyroid medication screen before menopause?
I would consider screening. I mean, you don't have to get a bone density every 2 years. If you're premenopausal, you might just get one bone density and then wait until, if it's normal, for example, and then wait until after menopause to then, get your next bone density. But it's not a bad idea to screen if you have thyroid disease.
Can you talk about the IV treatment that you get once a year? Is it better or worse? Side effects of meds? Questions.
Sure. So the intravenous once yearly medication called Reclast, that's the brand name, is a bisphosphonate. It's the same as the pill medication that's taken either once a month or once a week. It is no better in terms of the effectiveness of the medicine. The only way that it actually is better is with regards to compliance, because if you get your treatment, you know that you're treated for the entire year, as opposed to, oh, I forgot to take my medicine this week, or I'm having trouble remembering to take it every month. So in that regard, it can be more beneficial, but in terms of the actual medicine itself, it's not any better than the pills for therapy.
Let's see. Are there any natural methods to help increase bone density?
Nothing aside from what I mentioned, like calcium, vitamin D supplementation, and weight-bearing exercise.
Let's see. How often do you recommend a bone density screening for a person in their 80s with a family history of osteoporosis?
So in general, bone density screening is done every 2 years. In general, your bone density doesn't increase or decrease that quickly, but it really comes down to what your insurance will pay for. And it's approved to be done every 2 years. That's just the way it is. So, and I don't, as a physician, I don't have, except in very rare cases, a reason to demand that it be done more frequently, unless there's something that I'm looking at specifically, meaning someone has a condition that I'm worried that their bone density has gone down more quickly. But so every 2 years screening is fine. And that's the general consensus and protocol.
Excellent, excellent. Should you get the CRX blood test prior to beginning an anabolic?
So you CRX. So you're talking about the C-telopeptide. These are the breakdown markers of bone bone breakdown markers that are checked generally in the urine. I'm going to assume that's what the person that asked that question is asking. I do not use those tests to make a decision with regards to treatment. I use them only in the setting sometimes of checking whether or not my patient is taking their medicine, because I may be told, oh no, I take my bisphosphonate, Dr. Roppelt, but I can tell you, if I check your C-telopeptide and it's high, there's no chance that you're taking your bisphosphonate. So I might use it in that context, but I don't really use it in making treatment decisions.
Let's see. We still have a very, very active discussion. Can you give us some helpful links that would be helpful in our reference about osteoporosis?
Sure, I will. I don't know if you all keep an email or an attendance
Sure.
record, but I can forward that to Karen to be distributed for anybody that wants any information about osteoporosis with regards to links on the online and things like that.
Sure, we'll be glad to. There's a question on what are some side effects of the meds used to treat osteoporosis? And have there been studies on people who did not use medication but did use exercise and strontium to see how they fared?
So with regards to side effects of medication, the biggest side effect that we worry about with the bisphosphonates, which is one of the most commonly prescribed category of medicines, is heartburn or GI effects. Now, it's in the context of already having heartburn issues, or if you don't take the medicine properly. We advise our patients that when you take a bisphosphonate, you have to take it either sitting up or standing. Don't lay flat or decide to do yoga and practice down dog, for example. And the reason for that is that the pill, if it washes back into your esophagus, it can burn the esophagus or irritate the esophagus. So one of the biggest problems is irritation to the esophagus. Aside from that, it's pretty inert. It really only affects and binds to bone. Very rarely, some patients will complain of bone pain, but I always question whether or not it's really from the medicine or from something else. But certainly that's been listed as a potential side effect. With regards to the intravenous or injection medications, Forteo, for example, can cause some mild dizziness when you take the dose, and that medicine is taken every day, so it's a self-injection once a day. It can occasionally make you feel a little dizzy, in which case I tell my patient, just take it before bedtime. The dizziness doesn't last more than, a few seconds to a minute, but just, make sure you take it when you're sitting down or laying down. Denosumab not much other than potential bone pain. Osteonecrosis of the jaw risk is the same as with all the other medications. So those are some of the side effects that, are most common.
We have one.
Oh, and then there was a question about strontium, whether or not strontium and exercise has been looked at to increase bone density. Yes, it has, and it seems that it does. It is not superior to the medications that we prescribe in exercise. So while yes, it can increase your bone density or might help maintain your bone density, I would not recommend it instead of the prescription medications that if you need to be on, that would be a better choice.
How do you get enough calcium without dairy using dark leafy greens in view of oxalate reducing bioavailability of calcium?
So that's a very specific question. Honestly, there's a web, I don't know the name of the link, but you can go online and search calcium containing foods or foods that are rich in calcium that are not dairy. That's about all I could recommend. I personally don't have a list of things that, or at least I can't give you, how many milligrams of calcium are in, say this food or that food, but you can look that up. But a supplement, honestly, if you don't have a history of kidney stones or, a reason that you can't take a calcium supplement, I would take a calcium supplement if dairy is a problem.
How do joint replacements affect osteoporosis?
They don't, except that you can't get a bone density test, say on a hip that's been replaced. So say for example, if you've had a hip replacement, your bone density test has to image the opposite side. If you've had both of your hips replaced, then those sites cannot be used for diagnosis. We can image the wrist and the spine. For any bone density test, you need 2 sites to be looked at. So usually it's the spine and the hip. If you've had hip replacements, it would be the spine and say the wrist. But otherwise, the actual hip replacement or, a joint replacement doesn't directly affect osteoporosis.
Let's see, OTC supplements are not regulated, so are there any brands that you recommend?
Not really. There's no, Caltrate. I mean, I really can't give a recommendation with regards to what calcium is better. D3 is certainly a better vitamin D than D2. Honestly, buy what's on sale. I know that, while they may not be regulated as carefully as, say, medications are, calcium is calcium. I would buy what's on sale.
Well, I would like to thank Dr. Roppelt for being able to do this talk with us, and for Karen to be able to coordinate these events for the Long Island Libraries through Stony Brook Hospital. And does anyone have any closing things, closing announcements, or anything you'd like to say before we close? You good, Karen? Okay. I thank you very much, and we'll see you again on the next talk, which is going to be in June, and it's going to be about, well, an issue that on Long Island we have quite a lot due to the deer, but it's going to be on ticks, Dr. Jerry Simons, and that'll be the June talk. Until then, we'll see you on the next talk. Be well.
All right. Thank you, everyone. Thank you for your attention, and enjoy the rest of your day.